Hematuria and proteinuria are common findings in primary care practice. Although the American Academy of Pediatrics eliminated routine urine screening from its preventive care guidelines a decade ago, many pediatricians continue to use screening urinalysis as part of their health supervision visits. Most pediatric patients who are diagnosed as having hematuria or proteinuria through screening UA do not have renal disease, and abnormal findings usually resolve on repeated testing. However, hematuria or proteinuria that persists on repeated testing warrants additional evaluation and, depending on history, along with initial evaluation in the primary care office, may warrant referral to a pediatric nephrologist for further management. Although guidelines put forth by the American Academy of Pediatrics do not recommend yearly evaluation of urine by dipstick analysis for children, regular routine screening of pediatric populations has been established in Japan, Taiwan, and Korea. Our practice recommends screening of certain patient populations at increased risk for renal disease over a lifetime. The most common tests used by clinicians for initial assessment of renal function or renal injury are the urine dipstick test and UA with microscopy, where urine is centrifuged, supernatant is removed, and urine sediment is examined. Table 1. Conditions under which children should have a yearly urinalysis performed under a microscope. Whereas UA with microscopy is laboratory dependent, the dipstick test can be performed quickly in the provider's office and can guide the clinician to evaluate the patient further. Urine dipstick testing should be performed on a freshly voided urine sample within hours of collection. If a specimen needs to be refrigerated, it should be allowed to return to room temperature before testing. All pads of the dipstick are fully immersed in the urine and then immediately removed from the specimen cup and placed on a horizontal surface. Results should be read within minutes, either manually or by automated analyzer. Providers should be aware that there are a variety of urine reagent strips on the market with a range of semi-quantitative concentration results that are not interchangeable between manufacturers. The urine dipstick tests for the peroxidase activity of hemoglobin. Thus, a dipstick that is positive for blood is actually positive for the detection of heme pigment, which may reflect red blood cells in the urine or other causes, such as hemoglobinuria or myoglobinuria. A colorimetric test is used for detection of urine protein. The dipstick measures albumin concentration as a surrogate for protein, turning different shades of green and ultimately blue, according to the concentration of albumin that reacts with tetrabromoethanol. Whereas the urine dipstick is usually the initial screening test for both hematuria and proteinuria, additional studies are used to better quantify and characterize abnormal dipstick test findings. These additional studies are discussed further in this review. Hematuria, prevalence. Hematuria, a finding not uncommon to pediatricians, can be benign or can be a sign of a serious underlying condition. Population studies from the 1970s to the 1990s of school-age children suggest that approximately 1% of them have a or more urine dipstick test positive for microscopic hematuria, with persistence of hematuria at 6 months in 1/3 of this population. Definitions and measurement methods. Macroscopic hematuria is characterized by the presence of blood in the urine in sufficient quantity to be visible to the naked eye. Grossly bloody urine may appear pink or red, but may also be tea-colored or dark-colored with glomerular etiologies. As little as 1 milliliter of blood per liter of urine can induce a visible color change, and as little as 2 to 3 RBCs per high-power field can make the urine dipstick positive. To our knowledge, there are no published data that correlate the number of urine sediment RBCs with the dipstick results 0 to 3. On the other hand, microscopic hematuria is hematuria in the absence of visible color change in the urine, detected only by urine dipstick and confirmed by microscopic examination of the spun urine sediment. The definition of microscopic hematuria varies from 1 to RBC HPF, however, based on previous studies in school-age children. We define microscopic hematuria as greater than 5 RBC M&M in uncentrifuged urine or greater than 5 RBCs HPF in centrifuged urine on at least 2 to 3 different occasions. Microscopic hematuria that might undergo further evaluation should be independent of trauma, exercise, menstruation, or sexual activity. When gross hematuria is suspected due to a change in urine color, the first step in evaluation is centrifuging a fresh sample of the discolored urine. A positive urine dipstick that results from myoglobinuria, as in the case of increased skeletal muscle breakdown or hemoglobinuria, is typically associated with discolored urine without RBCs noted on microscopic evaluation. On the other hand, discolored urine with a negative urine dipstick should prompt questioning for and/or inclusion of other pigments, drugs, toxins, lead. Figure 1, approach to a child with microscope to urinary stream, the pattern of the hematuria, and associated signs, symptoms, illness, or activity. Transient hematuria has been found in association with fever, exercise, urinary tract infections, and trauma. Passage of fresh blood with or without clots at the beginning or end of the urinary stream should prompt consideration of lower urinary tract origin, with urethritis, trauma, bladder calculus, or mass, and schistosomiasis as possible etiologies. A detailed history of presentation should prompt a search for associated findings. Persistent hematuria is defined as more than 4 to 6 weeks of positive UA results showing more than 5 RBC HPF in the absence of exercise, activity, menses, or trauma, and can be categorized based on whether the hematuria is glomerular or non-glomerular in origin. Non-glomerular causes of hematuria. Hypercalciuria, defined in children older than 2 years of age as a urine calcium, creatinine ratio greater than OA, has been associated with persistent asymptomatic microscopic hematuria. Because infants are known to have higher calcium excretion combined with a lower urine creatinine level. A urine calcium creatinine ratio less than 0.8 is deemed acceptable for infants younger than 6 months and less than 0.6 for infants 6 to 12 months old. Hypercalciuria may be an isolated finding or may be associated with nephrocalcinosis or Frank Stone disease. A recent retrospective cohort from the United Kingdom noted hypercalciuria in up to 15% of 511 children with nephrolithiasis. Although other groups have described hypercalciuria in patients with urolithiasis to varying degrees from 7% to 34%, nephrolithiasis may be associated with microscopic or macroscopic hematuria, and depending on the location of the stone, may also be associated with moderate to severe abdominal and flank pain. Nephrocalcinosis is usually asymptomatic and discovered as an incidental finding on imaging tests, or otherwise discovered on imaging during an evaluation for microscopic hematuria. Nutcracker syndrome is a vascular disorder characterized by compression of the left renal vein between the aorta and proximal superior mesenteric artery. Although Nutcracker syndrome is not common in the United States, studies in Japanese and Korean children have found up to 30% to 45% of Doppler ultrasonographic findings consistent with Nutcracker syndrome in the setting of unexplained hematuria. Although most often asymptomatic, this phenomenon can present with left flank pain or abdominal pain. Hematuria, which is more often microscopic than macroscopic, and varicocele. The venous compression in Nutcracker syndrome may be detected by Doppler ultrasonography or by computed tomography, magnetic resonance angiography. Glomerular causes of hematuria. In immunoglobulin and nephropathy, macroscopic hematuria appears concomitantly with infectious illness, most commonly viral, respiratory, or gastrointestinal in origin. Of 10, patients with IgA nephropathy have persistent microscopic hematuria between episodes of illness. Some degree of accompanying proteinuria, at least at times of intercurrent illness, is also common. Usually no family history of renal disease is found in these patients. The most common systemic vasculitis in childhood, IgA vasculitis, more widely known as Henoch-Schönlein purpura, is characterized by palpable purpuric lesions, oligoarticular and transient non-deforming arthritis, arthralgia, abdominal pain, and renal disease. Renal involvement has been reported in up to half of children with HSP, with a tendency toward an older subset that most commonly develops hematuria with or without RBC cast and no or mild proteinuria. Less than 5% of patients with HSP with this mild renal presentation develop chronic kidney disease, compared with 250% of patients with HSP with a more serious initial presentation that is nephrotic in nature. Patients with repeated episodes of isolated macroscopic hematuria are also at risk for CKD in the long term. Both IgA nephropathy and IgA vasculitis are considered related diseases and display similar histologic features in IgA deposits. Alport syndrome is a hereditary disease with both gross and microscopic hematuria that is associated with high risk of progression to end-stage renal disease even before the 4th decade of life. The inheritance pattern is most commonly X-linked, but may also be autosomal recessive or dominant. The genetic abnormality that characterizes X-linked as involves the AA-5 chain-off type 4 collagen, and mutations in the COL4A and CCOL4A4 genes are responsible for the recessive and dominant forms of AS. Because type 4 collagen is found in the ear and eye, in addition to the glomeruli, as is often associated with high-frequency sensory neural hearing loss and ocular abnormalities, including anterior lenticonus. The rate of progression of renal disease depends on the nature of COL4A mutations. Thin basement membrane disease, also known as benign familial hematuria, is an autosomal dominant condition in which patients demonstrate persistent microscopic. Table 2, causes of hematuria in children. Post-infectious GN is the most common cause of acute nephritis in children around the world. Children aged 5 to 12 years are at greatest risk. Post-infectious GN has a in post-infectious GN usually resolves by 4 to 6 weeks. A low C3 level that persists beyond this time frame may warrant a renal biopsy, especially if there is continued hematuria and or proteinuria. Children tend to have complete clinical recovery and show resolution of the disease within 1 to 2 weeks. Microscopic hematuria can persist up to 6 months. Evaluation of hematuria. Children with 1+ blood on urine dipstick should have a UA with microscopic evaluation of the urine to verify the presence of urinary RBCs and to assess RBC quantity and shape. If RBCs are eumorphic, one should consider urinary tract infection, hypercalciuria, genitourinary malformation, and or familial causes of hematuria. Isolated microscopic hematuria has a good renal outcome in general, but the lifetime risk of CKD may be higher in certain patients, depending on the specific underlying disease. Microscopic hematuria is generally monitored on a yearly basis, but may require more frequent monitoring if associated with macroscopic hematuria and or proteinuria, because these can be associated with worse renal outcome. Furthermore, genetic analysis in the setting of a positive family history of hematuria and or proteinuria or ESRD has been recommended by several authors for early detection of rare progressive hereditary renal diseases, such as giant fibronectin glomerulopathy, C3, CFHR5GN, immunotactoid GN, and fibrillary GN, which were previously classified under the umbrella of benign familial hematuria. Therefore, these cases of persistent microscopic hematuria might also prompt consideration of subspecialty referral, especially if there is any family history of CKD. Proteinuria, prevalence. Although not always pathologic, proteinuria is recognized as a marker of kidney damage and is a well-known risk factor for progression to CKD in adults and children. The prevalence of proteinuria on a random urine specimen in otherwise asymptomatic school-age children and adolescents is approximately 5% to 15% based on multiple large-scale studies. This finding decreases substantially with repeated urine samples. One study examined 4 repeated urine specimens from each of approximately 9,000 children. One of 4 specimens was positive for protein in 10.7% of patients, but only 0.1% had 4 of 4 specimens positive with persistent proteinuria. The specific type of protein excreted in the urine, such as albumin or low molecular weight proteins, depends on the type of kidney disease. Albuminuria is more strongly associated with CKD as a marker of glomerular disease and is a long-term complication of diabetes and hypertension. In contrast, urinary loss of LMW proteins is more reflective of tubulointerstitial disease. For the purpose of this review, the term proteinuria refers to increased urinary excretion of albumin and or other specific proteins, such as immunoglobulins or LMW proteins. Definition. Although a small amount of protein in the urine is considered acceptable, proteinuria is defined as protein excretion greater than 100 milligrams M3 per day or more than 0.2 milligrams protein mg creatinine on a single spot. Urine collection. In neonates and infants, a higher amount of protein excretion, up to 300 milligrams M, is allowed. Nephrotic range, proteinuria is defined as greater than 0.000 milligrams M2 per day or greater than 50 milligrams kg per day or a UP. C greater than A on a single spot urine collection. Measurement methods. Different methods are used to quantify the amount of protein excreted in the urine, with the urine dipstick being the most frequently used by primary care physicians. The dipstick largely detects albumin and does not tend to detect LMW proteins. Ranges can vary depending on the manufacturer for the purpose of this article. A negative urine dipstick for protein corresponds to a concentration of less than 0.015 grams DL of albumin in the urine. Trace corresponds to 0.015 to 0.030 grams DL of albumin in the urine. 1 plus corresponds to 0.030 to 0.100 grams DL. Of albumin in the urine, a corresponds to 0.100 to 0.300 grams DL. Of albumin in the urine, 3 plus corresponds to 0.300 to 1 gram DL of albumin in the urine, and 4 plus corresponds to greater than 1 gram DL of albumin in the urine. A false positive urine dipstick for protein can occur when the urine sample has a high specific gravity or is very alkaline. Contamination with antiseptic agents or iodinated radiocontrast agents can also produce a false positive result for protein. And as such, it is recommended to wait at least 24 hours after a contrast study to test for protein in the urine. A more accurate method of measuring protein in the urine is by 24-hour urine collection. Adequacy of a 24-hour urine collection may be verified by measurement of urine creatinine, which is approximately 15 to mg kg ideal body weight in females and 20 to mg kg ideal body weight in males. However, in infants and children, especially in those, proteinuria can be classified as transient, orthostatic, and persistent. Transient proteinuria, which can be defined as proteinuria noted on one or a occasions, but not present on subsequent testing, is often seen in the context of fever, exercise, stress, seizures, and hypovolemic dehydration status. Orthostatic proteinuria is characterized by increased protein excretion in the upright position, which returns to normal when the patient is recumbent. On average, these patients excrete less than 1 gram of protein in 24 hours in the upright position, and this normalizes to less than 50 milligrams in 8 hours of supine position. Orthostatic proteinuria is one of the most common causes of proteinuria in adolescents. It is diagnosed when a first morning urine sample is less than 0.2 milligrams protein, mg creatinine in the setting of a UPC greater than 0.2, or positive urine dipstick for proteinuria in a random urine sample. The pathophysiology underlying orthostatic proteinuria remains poorly understood, but the prognosis has traditionally been thought to be good. Studies from the 1960s to the 1990s on up to 40 to 50 years after the diagnosis of orthostatic proteinuria have reported a benign course for this condition, where mortality is not shown to be greater than the average healthy population, with similar demographic characteristics in the absence of other clinical evidence of renal disease. Based on the mechanism of the proteinuria, persistent proteinuria may be subclassified as glomerular, tubular, or overflow. Glomerular proteinuria refers to an anatomical or functional lesion in the glomeruli that results in an increased filtration of protein across the glomerular capillary wall. Tubular proteinuria is seen when there's an increased excretion of LMW proteins due to interference with proximal tubular reabsorption. Overflow proteinuria refers to an increased excretion of LMW proteins that results from marked overproduction of LMW proteins, leading to a level that exceeds tubular reabsorptive capacity. Overflow proteinuria is very rarely seen in children and is not discussed in this review. Among the most common causes of primary glomerular proteinuria seen in children, minimal change disease represents one of the most common presentations of idiopathic nephrotic syndrome. It classically presents in children as edema, a low albumin level, proteinuria, and hyperlipidemia in the setting of normal renal function and complement levels, an absence of hypertension and or gross hematuria. Based on this clinical diagnosis, corticosteroid therapy is recommended without a confirmatory diagnosis by renal biopsy, as more than 90% of cases will respond within 4 weeks. Based on the response and frequency of relapses, MCD can be further subclassified in a case where a patient is found to be corticosteroid resistant, or if the clinical laboratory presentation is different from that described previously herein, a renal biopsy should be considered. On histopathology, MCD glomeruli appear normal under light microscopy, but show characteristic effacement of foot processes on electron microscopy. In teenagers who present with massive proteinuria, or in children with proteinuria who are found to be corticosteroid resistant, one should consider focal segmental glomerular sclerosis in the differential diagnosis. This disorder is named after the typical histologic lesion characterized by some glomeruli with areas of sclerosis. Figure 2. Approach to a child with asymptomatic proteinuria caution items warrant urgent consultation with a nephrologist and an anti-nuclear antibody, Alwakun kidney urgery BP, or scarring, alongside areas of normal glomeruli. A recent study describes FSGs in up to 56% of children younger than 20 years of age with initial presentation of corticosteroid-resistant nephrotic syndrome. The histopathologic diagnosis of FSGS is notably more prevalent in black patients compared with white patients, which may be related to the higher incidence of apolipoprotein LA gene in this population. Primary idiopathic FSGs, where circulating permeability factors are thought to be involved in the pathogenesis, often presents with the classic nephrotic syndrome triad of proteinuria, hypoalbuminemia, and edema in the absence of identifiable risk factors, e.g., severe obesity. Decreased renal mass secondary FSGs, on the other hand, usually presents with subnephrotic range proteinuria in the presence of identifiable risk factors. Several genetic forms of FSCs have been described. Mutations are most commonly described in the nephrin gene and the podosin gene. Both follow an autosomal recessive pattern and usually present in the first year of life. In contrast, autosomal dominant forms of FSGs tend to present in adolescence or later in adulthood. Continued, nephrotic syndrome occurring later in childhood or adolescence. CNS is more commonly associated with podosin. Congenital nephrotic syndrome can be associated with a history of prematurity, low birth weight for gestational age, and large placenta. The significant urinary protein losses result in hypoalbuminemia, hypogammaglobulinemia, and dysregulation of the clotting cascade, which make these children prone to poor nutritional status and growth, as well as a heightened incidence of bacterial infection. Hematuria and proteinuria are findings that can be of concern to both clinicians and families. Fortunately, in the great majority of cases, repeated studies or further evaluation will reveal no abnormalities and little or no need for further evaluation. If hematuria and/or proteinuria is confirmed, a detailed history along with investigation for extrarenal symptoms, high blood pressure, and abnormal renal chemistries will be helpful when deciding who may be followed in the primary care office versus who to refer to nephrology for further evaluation and how soon to refer. Further studies, including additional laboratory work, radiologic imaging, and percutaneous renal biopsy, may be undertaken by the consulting nephrologist to elucidate the cause of the urinary abnormality and to guide management. Summary. Based on some research evidence as well as consensus